السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lecture on shock in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, the ILOs for this learning activity, and here we have the recommended learning resources. Shock may be defined as a pathophysiological state in which there is widespread serious reduction of tissue perfusion, which if prolonged can lead to generalized impairment of cellular function. The reduction of tissue perfusion decreases the availability of oxygen and nutrients to the cells of the body tissues, resulting in cellular hypoxia and energy deficit, leading to generalized impairment of cellular function and cell death, which might be followed by organ failure and whole body failure and death. Let's describe the pathways leading to the decreased tissue perfusion and shock. Decreased tissue perfusion can result from hemorrhage or hypovolemia, acute heart failure, or neurogenic injury. Decreased tissue perfusion and cellular injury can then result in immune and inflammatory responses. Alternatively, the elaboration of microbial products like endotoxins and the release of endogenous cellular products from tissue injury result in activation of receptors, hence cellular activation, which influences tissue perfusion, resulting in the development of cellular hypoxia and shock. Now, a very important question arises, what drives the blood along the blood vessels after it has left the heart? You all know the answer for this question. It is the mean arterial pressure, which is the force that drives blood along the blood vessels after it has left the heart. And we mentioned in the previous lectures that the mean arterial pressure is equivalent to the cardiac output multiplied by the systemic vascular resistance. Thus, reduction in either component, the cardiac output, or the total peripheral resistance, without a compensatory elevation of the other, will result in hypotension. This table summarizes the types, causes, and clinical pictures of the different types of shock. The types of shock includes hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock, which is also known as vasogenic or low resistance shock. The causes of hypovolemic shock include bleeding, which could be either internal or external, dehydration as a result of severe vomiting or severe diarrhea, plasma loss as in burns. These result in low blood volume, hence the cardiac output is decreased, leading to hypotension. The clinical picture, the symptoms and signs of hypovolemic shock include hypotension, which is the most important sign of shock, weak but rapid pulse, cool, clammy skin, rapid, shallow breathing, anxiety, and altered mental state. Cardiogenic shock might develop when there are heart problems, like myocardial infarction, heart failure, and cardiac dysrhythmias, leading to decreased myocardial contractility, resulting in lowered stroke volume, hence decreased cardiac output and hypotension. The symptoms and signs of cardiogenic shock are as for the hypovolemic shock plus distended jugular veins and elevated jugular venous pressure and maybe absent pulse. Obstructive shock develops when there is circulatory obstruction, as in cases of constrictive pericarditis, inflammation of the pericardium, and cardiac tamponade, where there is accumulation of fluid in the pericardial sac, also in cases of tension pneumothorax and pulmonary embolism. These causes result in reduced blood flow to the lungs, hence decreased cardiac output, leading to hypotension. The clinical picture of obstructive shock is as for hypovolemic shock plus distended jugular veins and elevated jugular venous pressure, and pulsus paradoxus in cases of cardiac tamponade. Distributive shock, which is also known as vasogenic shock or low resistance shock, is further subclassified into septic shock, anaphylactic shock, and neurogenic shock. In septic shock, infection results in the release of bacterial toxins which activate nitric oxide synthase enzyme in the macrophages, leading to production of large amounts of nitric oxide, which result in vasodilatation and decreased vascular resistance, leading to hypotension. Hence, in septic shock, there is hypotension, fever, warm and sweaty skin, unlike what we have here in hypovolemic shock, where the skin is cool and clammy. In anaphylactic shock, where there is allergy and release of histamine, there is vasodilatation induced by the release of histamine, hence the vascular resistance is decreased, leading to hypotension. In anaphylactic shock, there is skin eruptions because there is allergy, and there is breathlessness because of the constriction of the airways. There is coughing, localized edema, and weak rapid pulse. Neurogenic shock arises as a result of spinal injury, leading to loss of the autonomic and motor reflexes, hence reduced peripheral vasomotor tone, leading to vasodilatation and a decrease in the peripheral vascular resistance, resulting in hypotension. The clinical picture of neurogenic shock are as for the hypovolemic shock, except that the skin will be warm and dry. Pathophysiologically, shock passes through several stages, including the initial stage, the compensated stage, which is known as stage 1, then the progressive stage, which is known as stage 2, and finally the refractory stage, which is referred to as stage 3. In the initial stage, there is little drop in the systolic arterial blood pressure, which continues to drop a little bit in the compensated stage, because the compensatory mechanisms would try to elevate the systolic blood pressure back to the normal level. However, in the progressive stage, the systolic blood pressure is markedly lowered, with further marked reduction in the systolic blood pressure in the refractory stage. In the initial stage, there is little increase in the heart rate, which increases further during the compensated stage as a result of the compensatory mechanisms. The heart rate increases further in the progressive stage, with very marked increase in the refractory stage. Hence, the heart rate increases to a very high level. Then, when cardiac function is suppressed, the heart rate markedly decreases. The bicarbonate level in the initial stage, there is very little decrease in the bicarbonate level, with little reduction in the bicarbonate concentrations in the compensated stage, and progressive decrease in the plasma bicarbonate concentration in the progressive and refractory stages. On the other hand, the concentration of lactic acid increases a little bit during the compensated stage, and there will be progressive increase in lactic acid concentration in the progressive and refractory stages, leading to lactic acidosis. Now, let's describe the stages of hypovolemic shock in more details. The stages of hypovolemic shock begin with stage 1, the compensatory stage or the compensated stage. In healthy individuals, acute blood loss of 10 to 15% of the blood volume, as for example during blood donation, results in activation of the sympathetic nervous system, and compensation is achieved quickly by increasing the heart rate, constriction of the arterioles. Hence the cardiac output would be normal or slightly reduced, especially when the patient assumes an erect position. In stage 1 hypovolemic shock, the arterial blood pressure is maintained, and the pressure might decline when the patient assumes the erect position. And the symptoms and signs also include increase in the heart rate, paleness because of cutaneous vasoconstriction, and anxiety as seen in the opposite figure. Stage 2 in hypovolemic shock, which is also referred to as the progressive stage, this is characterized by maximal mobilization of the compensatory mechanisms. When 20 to 40% of the normal blood volume are lost, the cardiac output will not be maintained, and it falls markedly even when the patient is in the supine or the recumbent position. Accordingly, there will be massive activation of the sympathetic nervous system, resulting in intense arteriolar constriction in the vascular beds of the kidneys, gut, and the skin. This is important because this results in redistribution of the blood flow. In other words, centralization of blood flow, with larger fractions of the reduced cardiac output going to the vital organs, which include the heart and the brain, and smaller fractions of the reduced cardiac output going to the kidneys, gut, and skin. However, despite intense arteriolar constriction, the systolic arterial blood pressure declines by about 10 to 20 millimeters of mercury. There is also generalized venoconstriction, resulting in reduced venous capacity, hence increasing blood volume in the circulation, and this tends to sustain venous return and elevates the cardiac output. Fluid also moves from the interstitial to the intravascular compartment as a result of reabsorption of the tissue fluids. The symptoms and signs and complications of the progressive stage in hypovolemic shock include a decline in the systolic arterial blood pressure by about 10 to 20 millimeters of mercury, tachycardia, where the heart rate increases and the pulse is freddy and weak, skin is pale and cool, so peripheral pallor is common because of the intense cutaneous vasoconstriction. There is deterioration of the mental state of the patient because the brain is getting less oxygen, and the patient looks weak, tired, and drowsy. Patient may show anxiety, aggressiveness, and restlessness. The patient will also feel thirst as a result of activation of the thirst mechanism through angiotensin II, as we will describe later in the lecture. Patients in stage 2 hypovolemic shock may also have oliguria with reduced urinary output, and in those who have intrinsic coronary vascular disease, inguinal pain might be experienced, and there is also drops in the pH and the development of metabolic acidosis due to the increased anaerobic glycolysis. Stage 3 hypovolemic shock is the refractory stage, is the irreversible stage or the decompensated stage through which the subject will pass when he or she loses more than 40% of the total blood volume. The compensatory mechanisms are already maximally mobilized in stage 2 hypovolemic shock. Thus, any small additional loss of blood, when the blood loss exceeds 40% of the total blood volume, this can result in life-threatening reduction in cardiac output, blood pressure, and tissue perfusion. Blood flow to the heart, brain, and kidney is further reduced, leading to severe ischemia and irreversible tissue damage, which may result in impaired organ function, leading to organ failure and death. The severe vasoconstriction may itself become a complicating factor and initiate a vicious cycle, as we will describe later in the lecture. Thus, stage 3, the refractory stage, the irreversible stage of hypovolemic shock, is complicated by major organs failure. Now, the factors which determine the ultimate outcome of stage 3 hypovolemic shock include the duration of stage 3, the severity of the tissue anoxia, hypoxia, and also the age and the condition of the patient. Now, let's describe the compensatory mechanisms which are activated during hypovolemic shock. These include cardiovascular compensatory mechanisms, respiratory, endocrine, renal, and other compensatory mechanisms. The cardiovascular and respiratory compensatory mechanisms during hypovolemic shock are rapid and act within seconds to minutes. The cardiorespiratory compensatory mechanisms during hypovolemic shock include activation of the arterial baroreceptor reflex, and this reflex was described in details in the 2 lectures on arterial blood pressure and its regulation. Also, we have activation of the arterial chemoreceptor reflex, and similarly this reflex was described in details in the 2 lectures on arterial blood pressure and its regulation. In short, Activation of the arterial chemoreceptor reflex results in enhancement of the existing tachycardia and vasoconstriction and respiratory stimulation leading to tachypnea. The cardiorespiratory compensatory mechanisms in hypovolemic shock therefore result in arteriolar constriction. This increases the total peripheral resistance and hence the mean arterial pressure, and this is brought about by activation of the arterial baroreceptor reflex and the arterial chemoreceptor reflex, and by the noradrenaline adrenaline vasoconstrictor mechanism due to activation of the adrenal medulla. Vasoconstriction is also produced by vasopressin vasoconstrictor mechanism, as we will explain in the subsequent slides. Vasoconstriction is marked in the cutaneous circulation, leading to cool, pale skin, and in the kidneys, resulting in drop in the glomerular filtration rate and urine volume, and in other viscera. However, flow to the heart and brain is maintained. The cardiorespiratory compensatory mechanisms in hypovolemic shock also result in venoconstriction, which is produced by activation of the arterial baroreceptor reflex and the arterial chemoreceptor reflex, and also by the noradrenaline adrenaline vasoconstrictor mechanism, and also by vasopressin. Venoconstriction is important because it reduces the venous capacity, resulting in shifting of the blood from the venous reservoir into the circulation, hence maintaining the filling pressure of the heart by increasing the venous return. The cardiorespiratory mechanisms also result in tachycardia, which is produced by activation of the baroreceptor reflex, the arterial chemoreceptor reflex, the increased sympathetic activity. Also, we have tachypnea, which is caused by the activation of the arterial chemoreceptor reflex and sympathetic overactivity. Tachypnea is important as a compensatory mechanism in hypovolemic shock because it increases oxygen delivery to the tissues, and it also increases the activity of the thoracic pump, hence helping in increasing the venous return to the heart. The increased sympathetic activity also causes restlessness, which increases the skeletal muscle activity, and this also helps in elevating the venous return, as we described in the lecture on the venous return. Now, these are the changes in heart rate, stroke volume, cardiac output, the total peripheral resistance, the mean arterial blood pressure, and the vascular resistance through the brain, through the gut, and blood flow through the brain and through the gut before bleeding and during bleeding, and when the cardiorespiratory compensatory mechanisms are activated. And all these mechanisms and changes were described in details in the 2 lectures on arterial blood pressure and its regulation. Now let's describe the endocrine and renal compensatory mechanisms during hypovolemic shock. Some of the endocrine and renal compensatory mechanisms during hypovolemic shock are activated within hours, and others are activated from hours to days. These renal and compensatory mechanisms in hypovolemic shock include release of hormones that initiate vasoconstriction, and renal conservation of salt and water, and the stimulation of hematopoiesis by erythropoietin. So here we have a table which summarizes the endocrine and renal compensatory mechanisms. So we have increased circulating vasoconstrictors, The stimulation of the sympathetic nervous system results in release of epinephrine and norepinephrine from the adrenal medulla. Epinephrine is released almost exclusively from the adrenal medulla, whereas norepinephrine is released from both the adrenal medulla and the sympathetic nerve endings. Both catecholamines, epinephrine and norepinephrine, by acting on the alpha-1 adrenergic receptors in the smooth muscle cells of the arterioles, cause vasoconstriction. Antidiuretic hormone, which is also known as vasopressin, is actively secreted by the posterior pituitary gland in response to hemorrhage when the blood volume is lowered. Thus, hemorrhage stimulates the posterior pituitary gland, resulting in the synthesis of more antidiuretic hormone by the hypothalamus and the release of antidiuretic hormone, the vasopressin, from the posterior pituitary. The antidiuretic hormone itself is a potent vasoconstrictor, and it also acts on the collecting ducts of the nephrons, stimulating reabsorption of water. During hypovolemic shock, there is reduced renal perfusion, resulting in secretion of renin from the juxtaglomerular apparatus, and hence the generation and production of angiotensin II. Angiotensin II is a powerful constrictor, and it also releases aldosterone from the adrenal cortex and stimulates the thirst mechanism, as we will describe in the subsequent slides. With the endocrine and renal compensatory mechanisms, there is also increased secretion of glucocorticoids by the adrenal cortex, and this helps to maintain the blood glucose level. Also, the kidneys release erythropoietin in response to the decreased blood volume and hypoxia, resulting in stimulation of hematopoiesis and the synthesis of more red blood cells. The endocrine and renal compensatory mechanisms result in renal conservation of salt and water. Vasopressin, antidiuretic hormone, increases water reabsorption in the collecting ducts of the nephrons, hence elevates the blood volume and increasing the arterial pressure. Angiotensin II stimulates the release of aldosterone from the adrenal cortex, and aldosterone stimulates reabsorption of sodium chloride by the distal segments of the nephron, hence blood volume increases and the arterial pressure increases. The decreased arterial pressure lowers the perfusion pressure through the kidneys, through the nephrons, hence decreases the glomerular filtration rates, thereby decreasing the excretion of water and electrolytes directly. Here we have the actions of angiotensin II. Angiotensin II stimulates the release of aldosterone from the adrenal cortex, and antidiuretic hormone, the arginine vasopressin, from the posterior pituitary. Aldosterone stimulates reabsorption of sodium and water, and antidiuretic hormone stimulates reabsorption of water and also stimulates the thirst mechanism. Thus, the subject will feel increased thirst. These combined effects of aldosterone and antidiuretic hormone result in increased blood volume. Hence, the right atrial pressure increases as a result of the increase in the venous return, and we mentioned in the previous lectures that the right atrial pressure is the filling pressure of the ventricles during diastole. Thus, ventricular filling increases during diastole. Therefore, the end diastolic volume is increased, and by the Starling mechanism, stroke volume increases. Hence, the cardiac output increases, elevating the arterial blood pressure. In addition to the cardiorespiratory and the renal and hormonal compensatory mechanisms, we have other compensatory mechanisms which are activated during hypovolemic shock. These compensatory reactions include mechanisms which are activated within hours and mechanisms which are activated from hours to days. The responses which are activated within hours include the increased movement of interstitial fluid into the capillaries, and this is known as the capillary fluid shift, and also the increased production of 2,3-DPG in the red blood cells. And this is important in order to help hemoglobin to deliver more oxygen to the tissues, because 2,3-DPG results in reduced affinity of hemoglobin, hence shifting of the oxygen dissociation curve of hemoglobin to the right. And when the affinity of hemoglobin to oxygen is reduced, more oxygen is delivered to the tissues. We have responses which are activated within hours to days, and these include restoration of the circulatory plasma volume, which takes 12 to 72 hours to happen after moderate hemorrhage. Also, the restoration of plasma proteins, and this occurs in two stages. Number one, the rapid entry of preformed albumin from the extracellular stores, and this is followed by the hepatic synthesis of proteins over 3 to 4 days. Also, the restoration of red blood cells, and this also occurs in two stages. The first stage is the increase in red blood cells count in response to erythropoietin, and this happens within 10 days, and followed by the restoration of the red blood cell mass, which might take 4 to 8 weeks. This is a figure which summarizes the compensatory mechanisms in hypovolemic shock. Now, let's describe the irreversible stage, the refractory stage of hypovolemic shock in more details. In the irreversible stage of hypovolemic shock, a number of positive feedback mechanisms are initiated, leading to further reductions in the cardiac output and the mean arterial blood pressure, and hence more tissue hypoxia. This depends on the amount of blood lost, as we mentioned earlier in the lecture. And when blood loss is excessive and not immediately replaced, and proper treatment is not initiated rapidly and is delayed, this stage is reached and the patient dies. In this stage, there is also failure of the compensatory mechanisms. Thus, in the irreversible stage of hypovolemic shock, the severe vasoconstriction may itself become a complicating factor and initiate a vicious cycle through the activation of a series of positive feedback mechanisms. The impaired coronary perfusion results in cardiac ischemia, and this leads to depression of the cardiac function more and results in further lowering of the cardiac output. The reduced blood flow to the vasomotor centers in the medulla oblongata depresses the activity of the compensatory reflexes, including the arterial baroreceptor reflex and the arterial chemoreceptor reflex. Prolonged adrenal ischemia might result in acute tubular necrosis, and this may lead to prolonged post-shock renal insufficiency if the patient survives. Bowel ischemia leads to breakdown of the mucosal barrier, and this might result in the entry of bacteria and toxins into the circulation. Thus, in the irreversible stage of hypovolemic shock, a number of positive feedback mechanisms are initiated, leading to further depression of cardiac function and drop in cardiac output and in the mean arterial blood pressure, as we mentioned in this slide. In the irreversible stage of hypovolemic shock, there is also generalized cellular deterioration. The activity of the mitochondria inside the cells is depressed, hence resulting in lowered production of adenosine triphosphate. Cellular metabolism is inhibited, especially the metabolism of glucose, and this lowers the production of adenosine triphosphate. Further, the activity of the sodium-potassium pump is depressed because of the lack of adenosine triphosphate. Hence, there is reduced active transport of sodium and potassium ions across the cell membrane of the body cells, leading to the accumulation of sodium ions inside the cells, and also there might be rupture of many lysosomes. Hence, in the irreversible stage of hypovolemic shock, there are multiple organ failure, which might end in death of the subject. That's the end of this lecture, and here we have the intended learning outcomes again, and thank you very much for listening.